So welcome everyone to this webinar on management of long-term conditions during COVID. I'm Dr. Batty, I'm a GP in East London and I'll be chairing this webinar. So I'm going to start off by just going through some housekeeping and the main thing really is to try and avoid any background noise. You keep yourselves on mute and if you do that it'll just go for a better experience for everyone. We're going to aim to have this webinar published as a recording later on, so if you want to share it with others, that can also be done as well. So to begin with, I'm just going to share the presentation slides, so these are going to pop up on your screen. If you want to get these in full screen, then you can click on the webinar itself, and then you can pin it, and this will allow you to maximize the screen. Okay, so that's the introductions. I'm going to hand over to Rachel Roberts now, who is going to go through the introduction. Rachel.
Thank you. Excuse me, my voice is a little odd. Thank you so much. It's Rachel Roberts, GP, and one of the primary care deans for London, Health Education England, so supporting the So three of us together are going to co-facilitate the session today. So Osman, and thank you so much for helping us. Again, it's fantastic. Sally Armstrong, Advanced Nurse Practitioner, and then myself. So thank you so much everyone for joining. We started calls at the beginning of the COVID era to training hubs to see what the different needs were as this illness progressed and what our patients were needing from us. And in the second session of those series, highlighted was the need to talk about chronic disease management in the COVID era in primary care. So we're not going to focus specifically on how to manage each disease, but really it's about today getting an interactive session where you can share good practice around how to manage in this era. How do we manage chronic diseases remotely? So obviously we can see patients face to face, but the ideal is to avoid this where possible. And how do we empower ourselves in teams, all the professional groups that are entailed in primary and community care, so that we all have a really good part to play, but also that we're supported well by our teams. And of course, considering the patients as part of that team as well. So thank you. Let's move on to the next slide. So there's been a lot of focus, of course, in the press about intensive care, acute, and the question for all of us is, you know, what is important in primary and community care? What's really important for our patients? And these are some of the questions you posed us in the learning needs that you sent through previously before this session. This is from the Royal College of GPs, jointly with the BMA. And it's just a traffic light suggestion about how to prioritise care. And I've chosen the three sections that are around long-term conditions. So clearly showing in green potential groups that we should highlight as really urgently engaging with them to try and make sure that management is as good as it can be, and also that there's a plan in place in case those patients were to become unwell, either with COVID or with any other intervening illness. Or in terms of things that would need next attention, and red, the things that normally we'd be doing that really for the moment probably need to go on the back burner because of the high pressure there is around managing all of the other conditions and changing our systems. So if we maybe pop onto the next slide, that would be really helpful. So I think this, you may need to maximise this on your screen, this really highlights the importance of what we can do in primary and community care. The kind of magenta-y purple first steep curve shows the immediate mortality and morbidity of COVID-19, so everything we're hearing about in terms of hospitals, ITUs, etc. And then in green, you've got the impact, because of everything being diverted towards COVID management, the impact that can happen to patients' health because practice as usual maybe hasn't happened. And that can be on urgent non-COVID conditions, MIs, strokes, everything. And then we've got, following that, a third wave, which is a more deep bluey purple on this slide, which is really the impact of interrupted care on chronic conditions. And this, because of the prevalence of chronic conditions, the biggest impact, and something that we all have a chance to intervene and hopefully prevent really negative impacts from interrupted care. And then the fourth wave in the red long-term suffering that patients can have, the psychological trauma, mental illness, effects of the economic injury and burnout, which again we're going to see plenty of in primary community care, so how we can help with this. And so in a moment I'm going to hand over to Sally to focus more on the practical aspects, and also we'll move on to some small examples just to open up for discussion as to how we would manage conditions that we're normally totally comfortable with, but in this current COVID era. But I just want to highlight that we're going to send out with the webinar, and in fact attached to it we've collected some resources. The guidelines coming out thick and fast. So there's just on Thursday been a nice guidance for COPD and COVID-19, which has got recommendations for how to manage our COPD patients now, not the ones that have COVID-19, but in order to maximise their care. There's been a European Society guidance on people on ACE inhibitors, and there's been a whole range of ones on GP book and many others about managing most chronic conditions in relation to COVID, and also Osmond collated some resources around specific prescribing in these situations as well. So I hope you'll be able to get those resources as well. Anyway, I'd like very much to hand over to Sally now, who will help to know what we're going to plan to do now for our patients. Thank you.
Hello everyone, thank you for inviting me to talk about this. So this is, there's no right or wrong here. I want to start off with, this has been a bit of a brainstorm between us, and please feel free to chip in to anything that you think I've missed or that you don't agree with. So the theme box from the RCGP highlighted the need to monitor unstable diabetics. So I think in terms of safe to leave and what isn't, I think monitoring patients with unstable diabetes is one of the priorities, i.e. an HbA1c over 75. And I think that that would very definitely warrant a blood test to check whether you've adjusted medication, to check that that was working, and obviously for renal function as well. We've had a bit of debate over what level of blood pressure you can leave. So pre-COVID, if it was greater than 160 over 90, maybe you can leave it. If it's below that, maybe not. If it was above that, maybe there might be some adjustments for people with diabetes. I think we need to be honing in on patients who are requesting more than usual salbutamol inhalers, and patients with COPD requesting a rescue pack. We also need to have a radar on our patients who have severe allergies and possibly severe hay fever at the moment. That's quite prevalent, and it has actually been quite a nasty season so far. And then anyone with deteriorating renal function. And that was my list so far of what is safe to leave. We've obviously got the DMARD monitoring and INRs, but in terms of chronic disease, those were the things that I'd listed down. I don't know, Osman, if you had any others on your list.
Yeah, so there's quite a lot of resources, like you mentioned, to try and manage people with long-term conditions. And just to highlight what Rachel kicked off with, in that the reason we really want to focus on long-term conditions during COVID itself is that we are expecting a second wave, or the third wave after COVID, and how when things have settled down, of people with long-term conditions becoming ill, mainly because of the fact that they haven't been looked after, or they haven't attended as they probably would have done. So it's really important that we highlight that, really. The actual resources, what I can do is I can go through some of the ones that we've got already. So I can share on the screen. You can see a bit of a summary guidance of the kind of things that we are recommending people to have when they're at home, and they're managing different types of conditions. And these are the ones that Sally's already talked upon. And I think the main question really is with all of these things is what's really safe and what isn't safe, and these are the questions that often come up really, and we'll get Sally to share some experiences that she's had as well. But effectively, if you've got any questions or you want to raise any points during this webinar, just type it into the chat, and what we're going to do, we're going to try and collate some of these questions and answer them as we go along to make it a bit more interactive. So please feel free to just use the chat to communicate with us as presenters. So Sally, if I go through first of all and just talk through the actual issues that you've had specifically in patients that you've seen. So if we start off with, for example, patients who require blood tests, how have you been managing those?
So yeah, so at our practice we do blood tests, but there's also what was a walk-in clinic, which is now no longer a walk-in. It has to be pre-booked. So just a word of warning there that if you do have any clinics that were previously walk-in, you need to check how patients can be seen in them. But we are doing urgent bloods at the practice. I don't know if all practices are, but we still are.
Yeah, and that's a really good point in terms of pre-booked clinics. And what we've done in our practice is that we've basically had patients coming in for bloods, but urgent bloods that are clinically led and not patient-led in terms of reviews. And we're calling them on the day to say, or they're coming in on the day that we're requesting to try to squeeze them in, mainly to just make sure that A, they don't have any active symptoms, and even if they don't, we're still ensuring the staff have got adequate PPE for doing this phlebotomy, just to make sure that we're all kept safe. And then one of the other tips that we've started doing now is we've asked patients to come in, if they're coming in for blood tests or anything else, and to wear a mask themselves, just so that they are protecting themselves, and we'll just make adequate precautions to safeguard all of us.
We give them a mask on entry, so. Yeah,
absolutely. And there's just a question from Francis about long-term mental health conditions. And mental health conditions is also quite challenging, and a lot of that you need to actually often physically see the patients. And I'll talk about video consultations, but how have you been managing those in your practice?
Yeah, we've been doing telephone or more recently video consultations. Ironically, a couple of mental health patients have actually refused video consults and preferred telephone, which is obviously a personal choice. There's the option for both, but we've been doing an ordinary consultation length, and I think they've been fine. I haven't got any adverse effects from it yet. Some patients have been tricky to get hold of. They haven't been answering their phones, so that's a bit of an issue. But when they do, that generally it's been okay.
And it does really bring up some of those things around, do we have the right patient's contact details, for example, to make sure that we can actually make contact with them, and that can be really tricky, really. We've certainly started using video consultations in our practice quite a lot, and we're using it for general consultations, but also it can give yourself and the patient quite a lot of reassurance. And mental health reviews is one of those things where can really add to the conversation, as can, for example, consultations with children as well. So that's one thing that is being advocated more and more. And AccuRx is a tool that nationally we're all starting to see, and certainly if you're with EMIS or System 1 systems, AccuRx integrates really well. If you're on another system, there is some use of the tool, but it doesn't integrate as much. So certainly that's the methodology that we've been using to do video consultations. Just to pick up quite a few queries and questions coming through around AccuRx also, for example, sending patients a text message beforehand, or also for screening their condition. So I know certainly AccuRx have built some templates for asthma reviews, for example, so that rather than patients coming in for an asthma review. If you've just joined, could you please mute yourself? Thank you. Effectively, if patients are coming in for an asthma review, if they're being screened beforehand with the RCP questions, for example, that can give you a bit of a stratification of those who are at high risk or who aren't at high risk. And if they answer negatively to those questions and they're not having many inhalers, then that's an example of a patient who's relatively okay and doesn't need to be seen as urgently as someone else, for example.
Yeah, and I think that brings up one of the issues, and that's kind of we've got to be in a high trust environment at the moment with patients. There are obviously some issues where patients will say what you want them to say rather than what the truth is, but we're just going to have to accept that. And I think it's about reaffirming the reasons for the numbers. So the reasons why you don't want a low peak flow, the reasons why you don't want a high blood pressure, and trying to instill a sense of responsibility for the patients. But we sometimes as nurses can be quite untrusting in a way because we want to see it for our own eyes, and so I think we've got to exist in a much higher trust environment at the moment. So I just wanted to raise that one.
Yeah, absolutely. I'm just going to try and bring in Zenobia. Zenobia, you've made a really good point about UCLP developing an approach and looking at developing some targeted strategies and searches. So if you'd like to unmute yourself, and do you want to discuss and tell us what's being developed at UCLP?
Yeah, so thank you, Osman. Can you hear me?
Yes.
Yeah, perfect, thanks. So at UCLP, we've had some debate over this over the last few weeks for exactly the same reasons. We expect subsequent, I guess, a resurgence of our long-term conditions. And so in terms of our focus, just in terms, yes, there are things like mental health disease and other areas that we could focus on, but our priority remained for the respiratory conditions, COPD and asthma, and type 2 diabetes, just as an immediate response. With this, we've worked very closely with our partners to identify some definitions for targeted searches that we could then use for our practices, taking away some of that cognitive functioning that we need to develop these searches, so to make it easier to have targeted searches, defining what we would regard as being sort of the high-risk asthmatics, COPDs and diabetics. With that, we then developed a sub-stratification tool, which for asthma, for example, incorporates some of the ACT questions, the COPD, the CAT questions, and then we sub-stratify further. It's probably easier shared in a slide, which we can find a way of doing at some point, but there's still a bit of debate around what constitutes high risk, medium risk and low risk for type 2 diabetics. So it would be good to get some thinking around, clinically, we often base our judgment on microvascular complications as well as the macrovascular, so foot disease and retinopathy, as well as the HbA1cs. But with our approach, we're also incorporating things like frailty and other social factors, so alcohol, for example, and the number of medications and insulin usage.
Yeah.
Glycemic control. So it's quite a comprehensive package, which in a few sentences might be a bit difficult to explain fully. I think I've got some colleagues on the call. Deep is leading on the respiratory side of things, so perhaps we can ask some questions to Deep later if
yeah.
But I hope that gives you a bit of an overview.
Yeah. And is there a timescale for when these searches will be released to us in primary care to have access to?
Yeah, so we're looking imminently within the next week or so, and the searches should be deployable to currently the EMIS web IT systems. There is work being done around others, so for example, one potentially so with vision. The other thing to add here is each of these pathways aims to release the capacity from GPs. So we are looking then at deploying our HCAs, expert physicians associates, to run the low to moderate risk packages, using digital innovations to help with some of the personal care. So the self-management tools at home. We've got Asthma UK, we've got Diabetic, the My Diabetes and My Asthma, but we're not sort of endorsing particular products. We're just ensuring that there is an array of innovation there for us to use.
Okay, so what we'll aim to do is that if we can get these searches developed and we can spread them out pan-London, effectively these may be nationally agreed searches that we can circulate widely. So as soon as they're launched, we'll aim to circulate them and we can also assist in trying to get them converted to other systems just to make sure that we can get everyone engaged with a consistent approach. And I think that's one of the struggles we've had, particularly with identifying high-risk patients, and there's been a lot of confusion around this. But there is additional confusion around what's low risk, medium risk, or not high risk, and how do we manage that? And that's quite complex in itself, really. It will be good to have some guidance around that. I'm just going to look at some other queries and questions that have come in around group online group consultations. And is anybody doing that? If you are doing any online group consultations, it would be good to flag it up. And then we can have a look at sharing what you've done. And also,
Deborah says you.
Sorry?
Deborah says they are about to start group consultations.
Okay, so Deborah, okay. So Deborah, are you available? Can you come online? Can you unmute yourself and talk to us about what you've been doing with group consultation?
Well, yeah, I can't really talk to you about it yet because we haven't actually done it, but we're setting it up, so we should be able to report on how it's working soon. I think we've done one so far with diabetic patients, which actually was surprisingly effective. People did like it, so yeah, I think it'll be fine.
Brilliant. Okay, so so certainly something that we can look at doing innovatively. So there's loads of innovative ways of doing things that we would normally do, and patient participation groups. I know there's certainly some of those that are active online, and they can be mobilised to help support us as well. There's another question about INR, and do we do home visiting services, or do we switch them to DOACs, or if they're not suitable, what do we do? Sally, do you have any experience on what you've seen patients who need anticoagulation?
So yes, we've obviously tried to reduce that workload as much as possible, and my colleagues have been working hard to get as many suitable patients onto DOACs as they can. There are obviously a group of patients who either aren't suitable or can't or are unwilling. We've tried to twist arms of a few people, but yeah, there are still some patients that need to come in and have their INR checked, and we're trying to widen the lengthen the time in between checks, etc. So, but yeah, we've just tried to be pragmatic and get as many patients onto DOACs as we possibly can.
Yeah, and I think that's the sense that I tend to see as well. So those who can be converted to DOACs are being converted, and those who aren't, we're just trying to be pragmatic as to how often we need to be doing their testing, really. So that's really, really, really interesting. So. And what about other things like, for example, resources that you give to patients? Have you changed the way that you give resources to patients because we're doing things remotely?
We haven't been, but you have, haven't you? You've done something about handing out blood pressure monitors.
So yeah, so there's various things that we can do. So there's lots of resources that we've done in terms of referring people to giving them text, and also having a look at home blood pressure kits and having a home kit for people, particularly if they're unwell. I'm going to bring in Phil here. So Phil Bennett-Richards is a GP in Tower Hamlets and part of the area where they've set up a home visiting or remote monitoring service. Phil?
So the GP Care Group, the Federation in Tower Hamlets, have set up a system where those patients with COVID are having a home monitoring kit. So there's a blood pressure monitor, a pulse oximeter, and a thermometer, which go out to patients using some volunteer deliverers. And then using the Accurix template, the data is fed back to either the central hub or for those practices who want to manage that data themselves. to track people with COVID who are in the community without a face-to-face consultation and identify those who perhaps are at higher risk or also maybe their indices are changing. So that's something we've done in Tower Hamlets. Is that what you're hoping for, Osman?
Yeah, absolutely. And I think that's the kind of thing which there's lots of innovation that's going on, and it's good to share these kind of things that are happening. And if you've got something interesting you're doing in your area, please feel free to share it, and we can just pick it up. And if we don't pick it up on the actual chat, we can certainly collate the information and send it around to you later on. There's a bit of information coming in around patients who are diabetic. There's the Desmond app, which is been made free for the time being, so patients can have access to that. And I think the same goes for a whole load of other resources and apps that is available, really. And I think the main thing, particularly as has been mentioned on the chat now, is around confidentiality when we're doing video consultations and group consultations, particularly because if we're using tools like Zoom, that's had a little bit of media attention around confidentiality and how we're using that particular platform. So it'll be worth making sure that everyone who's joining a group consultation, or if you're doing a particular a consultation with a patient, you make sure that you're using a platform that's relatively safe to use and safe for one-to-one. It's things like ActiveRx, which are verified and have a NHS digital certificate. Microsoft Teams is also now being advocated, although it does need a bit of setting up from your IT department to do group consultations, but that's certainly something that you can have a look at as well. So just bear in mind of getting great tools, but with these tools, there is a bit of responsibility that we've got to have, and using video, particularly if we're new to the environment, we need to be quite careful as to the governance around that, really.
Just on the confidentiality front, one issue that I've experienced is translation for patients who don't speak English, and just making sure that we've got in the notes approval for us to be able to talk to a relative or husband, wife about them, prior. But it's ever so tricky because obviously if it's not set up now, it's a difficult one to solve. But that's raised a couple of problems over the last week, being able to talk to somebody about a patient who can't speak English. So
yeah, and I think that's a really good point, really. It's all about documentation and who we're talking to, and whether there is a interpreter or a family member there. And just also reminded me about a tool that we've got locally, where whenever we open up a consultation, we've got an automatic protocol that comes up, which codes the fact that we are doing this consultation at challenging times, at times of COVID, just so that when we look back in future, we can see actually that this was a consultation that was done during COVID, so therefore the management may well have been a little bit different. So documentation is really important around that. Question about language line. Is language line still available? I think it is. So
it's tricky to use at the same time as a telephone consultation.
Yeah, so it's going to be a little bit more challenging to use that. If anybody's got any tips or any ways that they've managed to get around that, please share that as well. And somebody else was also mentioned around chaperoning during a video consultation, and it's all around good documentation and making sure that you would do as you would in a normal consultation, but you're just moving from a face-to-face to a video, so we have to be a little bit more careful as to how we do that and document, particularly if we're doing intimate examinations. So just a comment back around, yes, it is working, so language line, and you can do a three-way call, but then there's with the logistics. So on telephone, there's one thing, but maybe not on a video. It becomes a bit more tricky, although it is possible.
That's good to know.
Okay, brilliant. Okay, shall we look at some cases? And this might generate some other questions, and we can also feed into some other questions that have come up that are particularly around spirometry we can pick up in the next section. So what we're going to do now is that we're going to go through some common conditions that we often see in primary care and just discuss the ways that we would manage these differently during COVID. So I'm going to start off with hypertension and bring in Rachel. Rachel, do you want to introduce this case?
Yeah, thank you. And just in terms of the context, it's not a particularly unusual case I put in, but actually Fiona, who sent in some of the requests prior to this event, mentioned something extremely helpful, which was really talking about chronic care models and modifying components of service delivery. So I think that's what we're really talking about here, not about particularly cases in our presentation, but and she mentioned the 6 elements of this that we can modify in terms of how we organise what we do. So the first is organisational support, and some of that we've seen on a macro level, and that both Sally and Osman and all of you have just been talking about, things like what's available now through AccuRx, the other templates, the way we've moved so quickly towards video consulting where needed. Then things about clinical information systems. So again, we just talked about that and the security of them, potential risk stratification coming through. I think the 3 things that Fiona highlighted before was delivery system design. So I think this is what we're talking about. How do we as clinicians engage slightly differently with patients because of the restrictions that are placed on us at the moment? And the example just then given of delivering things to the front door for remote monitoring is a really good example. And in Sally's resources that she's attached to this, and Osman flashed onto the screen a while ago, it showed some of the home monitoring kit for each of the chronic diseases that actually would be better to have available for patients now than usually. And then decision support. So some of the learning needs that some of you sent through before this session was the confidence to work as you normally would, but having to work in this different way, and making sure you do have a peer member of your team that you can talk to about anything that you're concerned about. And actually, I find one of the beauties of either telephone consulting or video consulting is that actually you can do it in several bits if you need to go away and check something. So we can make a strength out of this. And then self-management support, I think we've touched on that as well, the thing with setting up potentially remote group consultations, and self-management is going to be so much more key in this current era, is really patients. And then finally, the community resources. So I'll touch on that in this case, if that's okay. So this is just a case of somebody, a gentleman aged 75, who has a reasonably long history of hypertension on bendroflumethiazide 2.5 and amlodipine 10 milligrams, and the blood pressure has been previously well controlled. You're now catching up after having to reorganise all the systems in the last couple of weeks, and one of the alerts that's come through to you is this blood test from the very end of February showing an EGFR of 45, whereas it had been 62 in August 2019. So nothing dramatically complex, but made more so by accessing the different elements of care that you would want and making sure that you've decided whether it's more risk to the patient to be attending places for tests or not. So I suppose if anyone on chat wants to make a comment, so would you see this as being in a category that you manage urgently, so under the green category of doing something at this point, and if so, what would you do?
And Rachel, it's really interesting. So it's a really common case that we're going to see quite frequently. And like you've mentioned, you've got to look at the trend that you've looked at previously, and the control itself. And also, I suppose the thing that flags into my head is, does this patient have, for example, a home blood pressure monitor? And I suppose these are all the kind of considerations that we have to take into our thoughts.
Absolutely. So it's certainly not designed to be a tricky case, but just to think through something that we may all do lots of times a day. So does anybody want to either chat or speak as to whether they feel this needs action in the next period of time, next couple of weeks? And if so, what would you plan to do? And how can you get that organised in your area? Is it easy? Is it moderate difficulty? Is it very difficult?
So we've got somebody saying that they'd want to know the blood pressure reading. So I suppose that's historical and current. And if stable, they could just take off the bendroflumethiazide. That's one one opinion, and perhaps see if there's an alternative. And a really good point from Claire, who's basically said she'd just phone the patient and say, how are you feeling? Which
Yes.
is absolutely crucial, really. And also, do you have any other information, such as ACR, that needs to be done as well? But generally, somebody else also said the same thing. They'd want to get an updated blood pressure, stop the Bendro, and maybe switch medication. So there's more of a let's monitor the blood pressure and which are the main things that are coming back, really. So, Sally,
Yeah.
do you have anything to add?
No, I think, yeah, everyone said the same things. Check blood pressure. I'd probably want to do an ACR, maybe dip the urine.
Yes, I think that was certainly in my mind, and so we've got, this is really interesting now, so we're getting into a slight debate now on the chat, and this for me was one of the issues. So one person has said don't bring in for bloods unless they're unwell, although it can be asymptomatic, and then the next person is saying we do need to know the pattern over the previous months. So we've got a significant drop between last August and this February. Do we need to repeat this at this moment? So I think this is great. So we've got a debate on here now with some people saying, yes, you want to repeat it. You need to know if it's falling rapidly, and others saying not. We heard from you, Sally, and from you, Osman, that yes, people can have blood tests, and actually we're up and running to a stage which we've got really quite good provision. And I'm not saying there's a right or wrong answer here, but it's a really good thing to debate, and this is why I put it into this case. So, Sally and Osman, what will your feelings be looking at the chat and what people have been saying?
Yeah. So I suppose from my point of view, it's really interesting. There's some really good points coming through from people, just from, you know, how is the patient? Are they shielding? Do they have any other test results that we can have a look at? So it is really telling me that we need to look at this as personalised care. So I suppose the first thing that comes into my head is that long-term condition management is as you would do normally. It is very personalised in terms of you don't just look at the blood test, look at the whole patient and manage them that way. And as long as they're relatively stable, you could just alter the medication, check their blood pressure, and repeat the blood test further down the line. Would probably be my thinking. Sally?
Yeah, I agree. I'd want to get a urine though.
Yeah.
I think that's,
Yes.
you know, that's a kind of a fairly easy thing to get, because somebody can pick it up from him, and drop it to the surgery, so he doesn't need to come out.
Yes, and I think from my point of view, when I was thinking about this person with a significant drop over the 6 months, I'd quite like to know the trajectory, not necessarily this second, but I think, and especially given the fact COVID is going to be going on a little while probably, I think I would be interested in making arrangement to repeat it, not necessarily right this second, but I think I wouldn't be happy to put that just in the to-do box when all of this is cleared up. But equally, I think it's just I just wanted to get the debate going. I'm going to take a second handover, but one of the points that can be even more difficult is the question of ACE inhibitors at the moment. So people will maybe have seen various articles about ACE2 ARBs and ACE inhibitors, and whether there is a problem with that in COVID, and whether it makes COVID more intense or severe if they get it. And there was a sort of a joint guidance given, and it was the third week of March, that at that time it was felt people should continue them, and it wasn't felt definite that there was a problem. But I think it's a case of watch this space. You may be getting a lot of patients coming to you worried who are on ACE inhibitors, and at the moment the guidance is to continue. There's a really interesting video on a GP notebook by David Miller-Jones about this specific question. So if you are getting lots of patients coming asking, those things are helpful, and it is in the resource pack that we're going to send out. Thank you, that's all from me.
Brilliant, thank you. Let's have a look at another case here. So we're going to talk about asthma. Sally?
Okay, so we have to be really careful with asthma, because obviously if somebody is presenting with a cough, we're obviously going to have to isolate them, because you can't rule out COVID. So What I would say with a cough and asthma is that they must keep taking their inhalers, their regular inhaled corticosteroids. And if their cough is going on longer than 2 weeks, then yes, we need to potentially look at their asthma not being well controlled. So just want to put that out there. The reason I've chosen this patient, so a 45-year-old lady, had asthma since she was a child. She also has hay fever and eczema. And she recently requested additional salbutamol, but without the inhaled corticosteroid. And the reason I've chosen her is because we are in hay fever season. We are seeing patients like this now. And we just want to, emphasise the need to continue taking inhaled corticosteroids, because I know there's been, again, like Rachel raised with the ACE inhibitors, some debate about taking steroids during COVID. They've unanimously decided that obviously taking your preventative inhaler is absolutely essential. But as I said, you need to just do a very, very good assessment of the patient and check that there aren't any COVID symptoms as well. And then you need to be looking at managing asthma in hay fever season with antihistamines, nasal sprays, eye drops, whatever is needed, and what they've had in the past as well. So we need to look at that. I don't think there's anything else. I have made some notes. Obviously, there's things about asthma management on a day-to-day basis that they want to be doing. Hopefully, patients will have a peak flow meter so they can measure their peak flow. Hopefully, they'll have an asthma action plan to hand so that they can reach for that and know what to do if they feel that it is their asthma that is poorly controlled. We need to be looking at potentially increasing or changing their medication or adding in, for example, Montelukast would be a good one to add in this time of the year. If we do think it's allergy related or even exercise related, believe it or not, I think people are exercising more now than they did pre-COVID because they're allowed to, which seems a bit ironic, but I have certainly talked to a couple of patients who have taken up running and have noticed their asthma is not great. And Montelukast is great for exercise-induced asthma. Obviously not first line though. And then we just need to make sure that our children with asthma are well looked after, and just knowing our risk groups, our high-risk kids, particularly our allergy kids. We just need to know who they are and check in on them and make sure they've got enough inhalers and they know how to take their inhalers. Signposting them to Asthma UK website for the inhaler technique videos, or Right Breathe. They've got them all attached to the inhalers that they specifically take. I think that was all I wanted to mention. Are there any questions?
So there's a lot of queries coming in around patients stockpiling medication, particularly salbutamol, which is something that I think people are getting concerned about, and if they're on these inhalers, they are certainly asking for more of. There's also, there was some debate around Clenil becoming a problem to get hold of, and pharmacists recommending to switch to QVAR. And I think the main take-home point with QVAR is that if you're switching from Clenil to QVAR, you've got to use half the dose because QVAR has smaller particles. So Clenil 100 is equivalent to QVAR 50, and I think that's really important to take note if you're struggling to get hold of medication, just to make sure they've got good equivalent medications. The other thing with hay fever that we've done specifically is making sure all patients have got their antihistamines, nasal sprays, eye drops on repeat, and encouraging them to request it online. So we're pushing the NHS app to say, download the NHS app, order your repeat medications online, and you don't have to come into the surgery, and they can manage their symptoms that way and take some pressure off the telephone triage that everyone seems to be doing. So they're the things to also think about, really. Should we move on to...
We don't actually prescribe them. We get them patients to buy them over the counter, I'm afraid. But
that's a really good point. So this will vary from area to area. So yeah, really good point. If you're prescribing them, then there's one thing about having them on repeat. If you're not, then you've got to make sure that patients are directed appropriately. Absolutely. Thank you for bringing that point up, Sally.
Somebody mentioned MART, so there shouldn't be any change to a MART regime. It's exactly the same principles with MART. So your regular doses of Symbicort, Durarest, Foster, and you can have up to an additional, well, you can have a maximum of 8 doses per day. If you need to go above that, well, if you need to do that for 3 days on the trot, then something's wrong. You need to contact the practice. If you need to, and hopefully doing that for 3 days will bring your asthma back under control. So there's no change to the MART regime in COVID. There shouldn't be any change.
And a couple of comments around Clenil. So 2 things. There are quite a lot of other generics available that are equivalent to Clenil, so certainly worth asking your pharmacy, local pharmacy about that. And also environmentally, if your patients are on 2 puffs of Clenil 100 twice a day, why not give them 1 puff of Clenil 200? It's a good tip.
Yeah, but you can't up and down it as easily with the Clenil 200.
Only if they're stable. Yeah.
Or you can swap to a dry powder, so an Easyhaler, which is much more environmentally friendly.
And that's really important, even though we're in COVID, we need to look after the environment even more so. Let's have a look at COPD now.
So COPD, again, you need to be ever so careful with COPD and COVID, but all that with somebody presenting with increased breathlessness. This is Mr. P, who's 78-year-old Afro-Caribbean chap who has moderate COPD on spirometry. He's a current smoker. He's never had an infective episode or infective exacerbation of COPD, and currently he takes tiotropium. He phones into the practice because he's becoming more breathless. So this guy, we need to make sure that the breathlessness is due to COPD. So that's the first thing that we need to do. So there's nothing else going on, no cardiac cause for breathlessness, no PEs, nothing acute, etc. So really, really good assessment of the breathlessness is needed here. And then if we are sure, we're happy that it's more of a chronic increase in his breathlessness, we can add in dual bronchodilation. But we also need to be getting him to stop smoking, preferably. Lots and lots of stop smoking apps that are absolutely brilliant, so he can get online and phone support for that. And hopefully as a practice you will be able to prescribe nicotine replacement as well. What else? So just making sure that he is actually taking his tiotropium, that would be appropriate. If you've not had an infective episode of COPD, I wouldn't necessarily be prescribing a rescue pack for this chap. I don't think that's necessarily needed. But if you have got patients who regularly exacerbate, then you want to be thinking about rescue packs and have they got them, know when to take them, have instructions with the rescue pack. Have they had their pneumococcal vaccination? We could debate whether that's justified as something to bring them into the practice to have or not. Are they eating okay? Are they getting their exercise? Again, that's really, really important. And then doing a sort of a SATs check on them would be useful. This could be done by paying the patient a visit if they're shielding, so that you could take the SATs monitor, hand it to them at a distance, put it on the doorstep, let them read their SATs, and go and pick it up again. Obviously, needing all the cleaning afterwards, etc. So this is possible to do. If anyone's got any other ideas here about this patient, then that would be great. But I think I've said everything about this patient.
So there's that interesting debate around the asthma may well be one that you could deal with on the phone and potentially just do it remotely just by doing some SMS. But COPD is slightly different. In this case specifically, where they're becoming more breathless, like you said, ideally we want to try and find out things like SATs, and logistically that's something that we need to think about how we're doing that within our practice networks or federations, and having a consistent approach where we can scale these things easily. The other query around COPD, which is off to a tangent slightly, is and links into Rachel's point around that third peak that we're worried about, is what about patients who we would normally just do a diagnostic spirometry on, but we're unable to at this time, and we are effectively delaying a diagnosis of COPD. Any strategies or thoughts around that?
I mean, we obviously can't do spirometry at the moment, and I would, if somebody is breathless and you need to rule in or out things, and sometimes an ECG may well be justified, a justifiable reason for bringing a patient in to have that done. And if you then can exclude a cardiac cause and you've got a high suspicion of COPD, I would be more than happy to start them on an inhaler, without having done spirometry, because if it isn't COPD and it doesn't benefit them, then you're going to know that. So I think the risk of doing that is fairly low. It's not, you've got to weigh up what harm are you doing, basically, and I think that's relatively, minor in comparison to them not having an inhaler. So
yeah. Absolutely. And I think that's a really, really good point. I think the main first thing is making sure they don't have COVID or anything that they need to go into hospital for. And if we're relatively certain around COPD as being a suspected diagnosis, coding it as suspected COPD, and a trial of treatment, absolutely. And I think that's what we should be advocating and documenting, that we're doing this at a COVID time. And yeah, I think that's a really good tip in terms of treat on suspicion if you can't get them in for a diagnostic test, really. Another good comment around smoking cessation clinics are still happening, and they're happening remotely, and that's absolutely something that we can all invest time in, and certainly our local areas are probably converting to that kind of service where they're offering services remotely for patients, and smoking cessation is one of those. Okay, I'm going to move on, and there's also just a few comments around pneumonia, pneumococcal jabs, and offering those to patients. Some people have had problems supplying them. Okay, let's have a look at the final case here. This is around diabetes. So I'll present this case. So this is something that is becoming more pertinent, particularly for diabetics who are planning on fasting, and that's been a real hot topic being debated. It gets debated every year, but specifically with COVID, it's been enhanced in our minds, really. So this is a 46-year-old taxi driver. He's been diabetic for the last 4 years. He is obese, and his HbA1c isn't great. And currently, he's on metformin at a full dose of 2 grams a day, and sitagliptin. And he's also planning to fast. And I think this is a really challenging type of case, which brings in the fact that you've got a poorly controlled diabetic, and the fact that he needs to fast, really. So certainly bring in your comments onto the chat, and we can talk through this case. But Sally, in terms of your experience with diabetics, let's take out fasting for the moment. But patients are, like you said, are taking up exercise more and more now anyway, so that's a good encouragement for them to lose weight. But have you changed your management of diabetics?
Oh gosh, I was hoping you wouldn't ask me this. I don't see many diabetic patients. We have got Francis on the line somewhere, who is a diabetic specialist nurse in the surgery. Francis, are you there?
Francis, do you want to come in? If you unmute yourself and share your thoughts.
Is she there? She's not. She's obviously disappeared.
Okay.
Oh, is she there?
Hi. I'm unmuted. Can you hear me?
Yes.
Yeah.
Yeah. I don't really want you to see me.
That's fine. So, what are your thoughts around managing diabetes?
So we haven't changed anybody's medication as such yet. I think it will be very interesting to see after all this whether the trajectory for HbA1c's goes up or down, really, and I don't think we've had enough time to know that. I'm still doing checks over the phone at the moment, insofar as that's possible. It is difficult. I'm finding it difficult without having recent blood results in front of me. And as I think we were discussing earlier about what is an urgent blood result, I am basing that, whether I bring them in for bloods, very much on just what's gone on before, and trying to, in my mind, it would really be helpful to have some specific guidelines, but in my mind, to categorize my high-risk patients and the ones that are less stable, and indeed the ones on insulin. I was also thinking another thing I would add to the list that was given before would be, you know, do they have a tendency to hypos? And also, there are some patients who've been on glycoside for a very long time. I don't really like glycoside, but, you know, also that's another issue because of the hypo risk. So, sorry, that's not a very
I think that's really helpful in terms of I think the message here is continue as normal, but the limitation is with the interpreting blood results. Certainly with home monitoring, we can get blood pressure and weight. Patients can tell us if they've got those devices to check those measurements, but it's the blood test. And like you said, we're having to change the way that we stratify who are we actually doing blood tests on, and it would be those who are more complex in higher risk categories, or those who have poorer control that we want to monitor more frequently, and they might be the ones that you bring in for blood tests sooner rather than anyone else really, and just focus your efforts there. The other things that I just want to highlight, just with the time we got left with Ramadan as well, if patients are unwell and they're on gliflozins, there's some guidance around we should be stopping the gliflozins, because there's a risk that patients can go into DKA at relatively low blood sugars with gliflozins. So we have to be a little bit careful with patients on gliflozins. In terms of planning to fast in Ramadan, there's lots of guidance that has come out, and we can certainly circulate that with this. But specifically, it's around making sure patients are well in themselves, and if they're unwell in any way, then we think about advising them not to fast, really. And there's a really good webinar, again, we can send a link to, with Professor Magdi Yaqub, who basically advocates anyone who's got any renal disease and is either on dialysis or has had a transplant shouldn't really be fasting, and patients with a GFR less than 45, again, we should be really advising those patients to be careful, because they're at higher risk of worsening their renal function during a fasting period. So we have to be really careful about those types of patients. There's a specific advice around switching medications, and I think, you know, it doesn't give it justice to just run through it too quickly, but in essence, you're looking to switch the morning medication to the evening medications to the morning, and ensuring that patients regularly monitor their blood sugars if they're diabetic and they're on either insulin or any anti-hyperglycemics like glycoside. So in a nutshell, that's probably what I would advise, really. And we can get a video circulated specifically on diabetes and renal disease, which is predominant in the population that's fasting. So that's that case that we discussed. So effectively, there's been quite a lot of questions and quite a bit of discussion that we've got through here. So what we're going to do, we're going to collate the information that we've gathered. Any queries and questions we haven't been managed to answer, we'll try and put them into a fact sheet, a Q&A type of section, and we'll circulate that, and feel free to circulate that on to other colleagues, and also feel free to share this webinar once we publish it to your colleagues who found it useful, really. Yep, there's a video that's been shared on the chat with CKD and Ramadan that you can certainly click onto now. So I think any final closing comments, Rachel?
An enormous thank you to you all, and thanks to Osman and Valley, but also to all the training hubs who I think are hopefully supporting people in each locality. And I think it's been fantastic getting all of you to let us know through the training hubs what it is you're needing at the moment. And so, you know, please continue to do that. If there are any future needs, we want to try and help, of course. And it's a time of massive change. So just an enormous thank you to every single person out there.
Okay. Thank you very much, and thank you all for joining, and we hope you found this useful and be able to manage your long-term condition patients much better over the next few weeks. Thank you.
Thank you.